by and large, we are numb to the noise of steatotic liver disease. You see it all of the time on every scan that is ordered. An abnormal ALT is now normal. A normal ALT is so rare in most of our patient panels. And what these studies and drug approvals mean is that this is the time to reevaluate our own patients for their risk of liver-related events. So there's a lot of hope bound up in it. Now that we have things that we can do, it validates the condition.
That's Dr. Elliot Tepper, the Academic Chief of Hepatology at the University of Michigan Health.
Welcome to Beyond Journal Club, a collaboration between CoreIM and NEJM Group.
The goal of Beyond Journal Club is to take landmark clinical trials and put them into context, telling you the story of how we got to where we are and then what it means to take care of our patients. I'm Dr. Sherry Trebetti, an internist at BADMC.
I'm Dr. Greg Katz, cardiologist at NYU.
I'm Dr. Clem Lee, a Med-Peds hospitalist in Boston and a guest editor at NEJM.
And I'm Dr. Alejandro Campos, an editorial fellow at NEJM.
All right, so today we're talking about MASLD, or as some people call it, MASLD, and MASH, as well as two approved drugs that help improve liver fibrosis in these conditions.
But here's the problem. I think most of us don't actually have a mental model for steatotic liver disease. So today we're actually going to start with one, a simple framework for why this disease happens. Two, how to screen and then risk stratify. And then three, the trials. Essence and MAESTRO-NASH, published in the New England Journal of Medicine in April 2025 and February 2024, respectively.
And it's important to cover it like this because once you understand the model, the trials and the mechanisms just make sense, including how two different drugs can tackle the same disease through completely different mechanisms of action.
A quick word from our sponsor, Oakstone CME MixApp Audio Companion. What if I told you that 11 minutes on your walk to work could help you prep for boards? Would you feel like that's worth it? That's how I think about it. The MixApp ACP Audio Companion breaks down topics into short, focused episodes, usually around 10 to 20 minutes. You can actually fit that learning into margins of your day. Take a listen.
If there's no obvious cause for the hematuria, then the patient should undergo renal function testing, cystoscopy, and imaging, and then nephrologic evaluation if there's proteinuria, erythrocyte morphology abnormalities, or other signs of nephrologic disease.
It's expert-led, high-yield, built for real-life learning, plus you earn CME while you're doing it. For me, it's less about finding time to study and more about finally using the time I already have. Use the code CORE25 for 25% off at the checkout. Visit oakstone.com/mixapp and use the code CORE25. I think a lot of us grew up thinking that cleaning products under our sink were just fine. But a lot of the conventional cleaners are loaded with chemicals that can irritate skin, disrupt hormones, and who knows the harm that they can cause over time. And that's why Branch Basics is something that I can feel good about, right? Everything they make is plant, mineral-based, fragrance-free, and certified human-safe, meaning independent scientists have screened every single ingredient against over 15,000 known toxic substances, and that is just the standard that Branch Basics goes by. And then on top of that, the refill system is just genius. You get one concentrate that dilutes into cleaners that you can basically use on every single surface of your home, from countertops to bathroom sinks to toilets. Less waste, less spending, less worrying about what you're spraying around your pets, your kids, your loved ones. And here's the good news. Branch Basics is now available at Target and Target.com, making it easier than ever to access safe, effective cleaning products. Whether you're going all in on safe cleaning swaps or just starting small, find Branch Basics at Target and Target.com today. All right, so let's start with one question. Why does fat even end up in the liver at all?
The simplest way to understand this is the bathtub analogy.
So bathtub analogy feels a little bit odd, but go with us. And so think of your body like a house and fat is water. The bathtub is your storage of water. That's subcutaneous fat. And subcutaneous fat is designed to safely store excess water that comes into the house.
Yeah, I'll admit, Greg, this is the first time I've heard of this analogy. But what happens when this tub starts to overflow?
Now, fat spills into places it doesn't belong and starts to get into the walls, the foundation, and other rooms. In this analogy, that is the liver, muscle, pancreas, and around the heart.
Yeah. And then here's the thing. Every single person is born with a different size bathtub, right? Their ability to accumulate different amounts of subcutaneous fat is different. And then once that bathtub is filled, we start adding visceral fat. Now, visceral fat is different from subcutaneous fat. It is toxic stuff that is going to cause the problems. The metabolic syndrome, the MASLD, the type 2 diabetes. These are all different expressions of the same underlying problem. Too much water in that bathtub that's overflowing to the vital areas of the house or into our bodies.
So MASLD, metabolic dysfunction associated steatotic liver disease, isn't really just a liver disease. It's what happens when the whole system gets overwhelmed.
So the first thing to recognize is that MASLD is a systemic disorder. It is the liver manifestation of the metabolic syndrome. Fat in the liver is just another risk factor for heart attack and stroke.
Right. And here's this key shift. When we see hepatic steatosis on imaging, we shouldn't be thinking, oh, this is a liver problem. We should actually think, okay, our patient's cardiometabolic risk just went up.
Yeah, so I co-sign that so strongly. MASLD crosses disciplines of medicine in a way that so few diseases do. And so when I started cardiology fellowship, I would have never imagined a radiology report with the words hepatic steatosis would make me better understand a patient's cardiometabolic risk, but it does.
Yeah, same here. I think the thing that trips me up, though, is that I've definitely seen patients with a normal BMI who end up having MASLD or MASLD. And then I've definitely seen people who are obese that don't have it.
Yeah, I think the best way to explain this goes back to the analogy. It's just that different people have different sized bathtubs, meaning everyone has a different capacity to store that fat subcutaneously.
Yeah, a big tub means that someone can store a lot more adipose tissue subcutaneously before it overflows to the organs. On the other hand, a small tub means that overflow happens early.
Yeah, speaking of small bathtubs, I am so jealous of people with big bathtubs. I recently learned that certain populations, particularly many Asian populations, have less capacity to store fat subcutaneously. So unfortunately, when there's excess fat, they're more likely to accumulate around visceral organs. And of course, that means higher cardiometabolic risk.
In fact, that's one of the reasons why BMI alone can be misleading.
And the analogy has even more complexity. I mean, after that overflow happens, not everyone develops the same damage. Where the fat goes is different. If it goes to the liver, that's MASLD. If it goes to the pancreatic beta cells, that inhibits our ability to produce insulin. If it's deposited in the muscle, there may be more peripheral insulin resistance.
Yeah, in other words, the capacity to handle excess adipose tissue is genetic, among other things. And so is which organs the extra fat goes to. And that's why the clinical picture can be so heterogeneous across different patients.
Okay, so say our patient does have excess adipose tissue that's gone to the liver. It could be MASLD, it could be MASH, or another acronym that I'm forgetting or might not be in vogue anymore. How should we think about this?
So Met-ALD is when you have fat attributable to the metabolic dysfunction and there's some ongoing alcohol use. But at some point, alcohol consumption is such that we now say that's the primary or if the sole driver. That's alcohol-related liver disease. If you see fat in the context of the metabolic syndrome, that is straight up metabolic dysfunction-associated steatotic liver disease, which I will call MASLD. Some people like MASLD. It's just totally random. And if it catches on fire, metabolic dysfunction-associated steatohepatitis.
And we'll link to a graphic that breaks down the distinctions among the steatotic liver diseases, but for the purpose of this episode, a simple way to think about it is MASLD equals fat in the liver and MASH equals fat plus inflammation.
Yeah, I always mix up those two and which one I should worry about more. But then I remembered that MASH ends with ASH, and that can help me remember, okay, MASH is the one where the liver is on fire because ASH could be like the inflammation that happens afterwards, and that's something we do not like. No ASH, no MASH.
I like that, Shreya. I think that's what I'm going to keep in my back pocket for the future.
Yes.
And the whole reason we care about this is that MASH accelerates the progression to fibrosis dramatically. And fibrosis, or scarring of the liver, is what really determines clinical outcomes. And advanced fibrosis impairs liver function and can progress to the list of poor outcomes we've all seen in the hospital, like decompensated cirrhosis, hepatocellular carcinoma, the need for liver transplant, higher risk of death, etc.
And here's where it gets tricky. Only 7 to 35% of patients with MASLD develop MASH each year.
Oh, so then most people with fatty liver will never have MASH or that active steatohepatitis or that liver on fire. That's good news.
And that heterogeneity is because some people's liver cells are just more vulnerable to lipotoxic injury. And so to keep going with our house bathtub analogy, their wiring is just more fragile. And unfortunately, we can't yet identify ahead of time who's going to have fragile wiring and who doesn't. And that's where screening comes in.
Yes, great segue to screening and staging. But before we do, let us summarize. So in terms of spectrum, if you see MASLD, that means there's fat in the liver. If you see Met-ALD, there's some alcohol involved also. Both of this, though, can lead to MASH. And remember, the ASH in MASH means that their liver is on fire, there is inflammation, and that is particularly bad because MASH accelerates fibrosis. And fibrosis, as Claude mentioned, is what we care about because it's shown to be the primary determinant of all the bad things, right? Cirrhosis, hepatocellular carcinoma, and other badness. So clinically, what I'm taking away is that we all need to make a mental shift that when we do see steatosis on that long imaging report, the next question should be, does my patient have fibrosis? And if so, how much? Because it's that fibrosis that's tied to outcomes.
And its first step is to calculate something called the Fibrosis 4 index or FIB4 index. All you need is the patient's age, the platelet count, and AST and ALT values. And it has good sensitivity for ruling out significant fibrosis when the score is low.
If the number is less than 1.3, then you're good to go. If the number is over 1.3, you might want to do another test like elastography. But if the number is over 2.67, that's the highest risk person.
All right. So I think I can remember that. Less than 1.3 means a low risk for fibrosis.
Yeah. And one age-related nuance is that the FIB4 uses age as a component, and that inflates the score in older patients. Score over 2 in someone over 65 is about equivalent to a score of 1.3 in a younger patient. And so we need to keep that in mind before we reflexively send every older patient for elastography.
Yeah. So I guess what I'm taking away is if I see a FIB4 score over 1.3 in someone younger than 65, or if I see a FIB4 score over 2 in a patient over 65 years old, that means, yes, go ahead, proceed to elastography. And there's many different types of elastography. And I think the one that most of us are familiar with or will hear about is the FibroScan.
I go to is vibration-controlled transient elastography, which has a brand name of FibroScan, although there are other alternatives that assess the viscoelastic properties of the liver. So we need to jiggle the liver to see how stiff it is, and that stiffness correlates with the presence of cirrhosis, yes, no, but also prognostically whether or not that person will go on to develop liver cancer or portal hypertensive events.
I don't know why that visual of like, we're just seeing how the liver jiggles is so memorable to me. And I've since explained that to so many patients and like, okay, let's go see how my liver jiggles and if it's stiff or not. Anyways, it's so cute. But then once you order it and you get the test results back, in terms of interpreting that elastography, there thankfully is a good way to remember the cutoffs and what it means.
And this is how this has transformed our way of communicating to patients, the rule of 5s. 5, stone cold normal, okay? Less than 10, low risk. 10 or above, you're at high risk for something called compensated advanced chronic liver disease. So 10, something's up. 15, cirrhosis. This is like some people over 15 don't have cirrhosis. They have stiff liver because of inflammation. And some people below 15 have cirrhosis. But 15, the test characteristics are pretty good. 20 is cirrhosis. And 25 is cirrhosis. And you actually think that the person has portal hypertension.
But the key limitation we should be explicit about is what the FIB4 and elastography can and cannot tell us. And so they still don't have any ability to detect active inflammation non-invasively. So MASH still requires a biopsy.
Yeah, and this really matters. Like, take 2 patients with identical FIB4 and elastography scores. One may have active MASH with fibrosis, while the other may only have fibrosis. So in that scenario, biopsy is the only way to distinguish them.
And if a patient has active inflammation, that distinction between inflammation and fibrosis matters because active inflammation means damage is ongoing and intervening is much more urgent than if there's just fibrosis without inflammation, where it's kind of like the damage has already been done.
The FDA requires that in order to achieve approval, these drugs must show on paired liver biopsy that there is a reduction in the steatohepatitis without a worsening of the fibrosis.
All right, but there is a problem with doing these invasive tests of biopsy on everyone with concerning FIB4 or elastography results. And that's because even biopsy results aren't that reliable.
If you took a biopsy from a patient's left lobe and from their right lobe, many people will have the same fibrosis stage, but at least 1 in 4 will not. And if you gave the same biopsy to two different pathologists, they will often disagree about the stage. And here's the problem. Sometimes you'll give that same biopsy to the same pathologist on 2 different days, and they will disagree with themselves. So for all those reasons and more, I am not going to require a liver biopsy to manage a patient. And I will arrive at a place that might be more certain using elastography.
And Dr. Tapper even acknowledged that what he does in practice might be different from another hepatologist.
So there's this drugs that have been approved are now based on biopsy. And some insurers or integrated healthcare systems have followed the letter of the law. After all, if this drug was approved based on a liver biopsy finding, then I should only be dispensing this drug for people with that liver biopsy finding. And you have to sometimes play by that rule.
So here's the biopsy paradox. In clinical trials, biopsy is the gold standard, but in clinical practice, we can often manage patients non-invasively using the FIB4 and elastography. So when we're thinking about who qualifies for these new drugs, that's where this tension actually matters.
Yeah, and hold that thought because that is a great segue to management. But first, let's recap the diagnostic tools that we do have. My takeaway is next time, if I see steatosis on a long radiology read, I'm going to go ahead and calculate that FIB4 score. And if it's over 1.3 in someone who is younger than 65 years old, or if it's over 2 in someone older than 65, I'm going to go ahead and advocate for them to get an elastography. And most commonly, you'll see the FibroScan, which the wonderful Dr. Elliot Tapper says it's that special ultrasound to see how much that liver jiggles to assess fibrosis.
Yeah, and then we cannot detect inflammation or fibrosis without a biopsy. And the problem is that there can be variability based on where the sample is collected and which pathologist is reading it that day.
So there's a lot of different layers of uncertainty here. And so this discrepancy among pathologists down the road opens the door to a potential paradigm shift in how we treat the disease. And it makes me wonder, how much do we truly know about the way we're managing this condition versus how much of how we do things clinically are just based on educated guesses with our current understanding of the physiology?
Yeah, I think what you're describing, Greg, is the tension between being accurate and precise about who truly has fibrosis, but then recognizing that our gold standard isn't really the gold standard because it's patchy.
Oh, is that a pun? Patchy? Like patchy areas of fibrosis? Well, that's what you literally are saying, right?
Yeah. So now that we have a way to identify risk and understand the biopsy paradox, let's move on to the management of MASLD.
And the first thing to know is that as weight loss proceeds, the fat will be removed from the liver, and with it, eventually the inflammation and even a remodeling of the fibrosis. So around 5% body weight loss is enough to start to drain fat from the liver. Around 7.5% body weight loss, you have an extinguishing of that fire, the MASH, or metabolic dysfunction associated steatohepatitis. And then about around 10 to 12.5% body weight loss, you'll actually see a reduction in the fibrosis.
So that statement is so biologically powerful. Patients so often feel like 10 pounds isn't an amount of weight loss that's worth celebrating. But 5% of body weight for a 220-pound patient is 11 pounds. And at that threshold, you're already starting to see improvements in the liver. This is meaningful biology. And even if it doesn't show up in the mirror or the way someone's clothes fit, it's worth celebrating.
Yeah. I love this idea so much of giving our patients a target. As someone who personally is like a numbers person and I'm very mission oriented, I love the idea of being like, hey, if you lose 7.5% of your weight, we can actually reverse the inflammation of the liver. Or if we get to 10% weight loss, we can actually see reduction in terms of the stiffness, the fibrosis of the liver. I think that's huge enough. I find it very motivating.
Yeah, sure. I feel like we're always playing good cop, bad cop in these episodes because I sort of want to say, yeah, 10% weight loss, that feels like a lot. Like just through lifestyle alone, I'm not sure that's very commonly achievable or doable for our patients.
And that discrepancy between what is ideally achievable and what is actually achievable is the whole setup for these trials. We just haven't had the tools to help our patients produce this weight loss reliably and durably until now.
And now onto the two trials. They test two different medicines, but the same idea. Fat is toxic, and if we reduce it, then we can reverse the disease. But they do this in two different ways.
Let's get back to that bathtub analogy. Our tub is overflowing into the liver and causing damage. And if we want to reverse that damage, we can either turn down the rate that the water is draining into the liver, or we can take that water out of the liver directly.
And that's exactly what these drugs do. Semaglutide works by slowing down the water coming into the bathtub, while Resmetirom drains the liver directly.
So let's start with semaglutide, the first of those drugs, which was studied in the ESSENCE trial. And I had to go to clinicaltrials.gov to really find what it stood for, ESSENCE. That stands for the effect of semaglutide in subjects with non-cirrhotic, non-alcoholic steatohepatitis. This study was registered in 2021, so I'm not taking off too many points for them using the old nomenclature NASH. However, I don't love that they were calling the participant subjects. It kind of feels sterile. So I'm just going to give this acronym a 6 out of 10. Final answer.
I'd give it at least an 8. I actually liked it. So talking about the trial. So the ESSENCE trial included about 1,200 patients randomized to a 2-to-1 ratio to semaglutide, 2.4 milligrams versus placebo. And all of these participants had biopsy-confirmed MASH with F2, F3 fibrosis.
Yeah, and then just for context, fibrosis is staged from 0 to 4, with 4 being cirrhosis, and then F2, F3, which is, these patients in the trial, that is moderate to advanced fibrosis on biopsy.
And as Dr. Tapper mentioned before, the co-primary endpoints in these trials are improvement of either MASH or fibrosis without worsening of the other.
Yeah, and the results were pretty impressive. At 72 weeks with semaglutide, 63% of patients had MASH resolution versus 34% with placebo. And 37% had fibrosis improvement with semaglutide versus 22% with placebo.
And the part that I found pretty wild is that semaglutide hasn't even been proven to directly act on the liver.
There are no GLP-1 receptors in the liver. When semaglutide is able to produce in a randomized controlled trial a reduction in fibrosis, it is doing so through general metabolic health. And it is a sign that the liver is basically a bystander in a systemic process.
And so this is the bathtub analogy playing out in the trial data. Semaglutide reduces water in the whole house and thus overflow from the bathtub. And so that leaves the liver a chance to heal. This tells us something really profound to me. And so fibrosis in MASLD is potentially reversible if you address the upstream metabolic problem, even if you don't target the liver directly, but at least to a point.
Oh, fair. But I just want to pause for a second. Did we just say that the placebo arm had 34% resolution of MASH and 22% of the patients had an improvement in fibrosis with just placebo?
This is what you see in virtually all drugs that have been studying this, because there's a lot of variability in biopsy reads. There's a lot of variability in the liver. And of course, people are getting a standard of care, lifestyle management, and there might also be regression to the mean.
Yeah, that's fair. It goes back to what we were saying. These biopsies aren't perfect. But even with that, if you just look at the numbers, 63% versus 34% or 37% versus 22%, these are large treatment effects by any standard.
Yeah, okay. All right. So that's the ESSENCE trial and what we saw in terms of data and outcomes. Let's move on to the second approach to tackle MASLD, Resmetirom. This is a thyroid hormone receptor beta agonist. So basically, it's targeting thyroid receptors in the liver. And I was today years old when I learned that there are thyroid receptors in your liver.
Okay, me too, Shreya.
Yes. Thank you for the solidarity.
Yeah, it's almost like a liver-specific thyrotoxic state where the liver cells speed up their metabolism and oxidize intrahepatic lipids, which basically burns the accumulated fat.
Yeah, what you're describing sounds like targeted fat reduction in one organ. So you get the metabolic benefits of thyroid hormone in the liver, but you don't turn the rest of the body thyrotoxic. I mean, that sounds like a win to me.
So hearing about this mechanism is one of those times when I marvel at just how freaking clever pharmaceutical companies can be. I mean, in the fitness world, this spot reduction idea, this is the concept that you can target fat loss in a specific body area through exercise or intervention. Spot reduction is considered a myth. You don't do crunches and selectively burn belly fat. You don't do tricep extensions and suddenly your arms become thinner. Fat mobilization during exercise is systemic, not local. And so Resmetirom, to my knowledge, represents the first time any kind of intervention, pharmacologic or otherwise, has achieved something biologically equivalent to spot reduction, selectively clearing fat from one specific organ, the liver, without requiring systemic weight loss. I mean, it's like miraculous. It's just astounding how clever this is.
Yeah, Greg, now that you say it out loud, I'm like, yeah, I didn't think about that. But then, so how did the Resmetirom actually do in real life when it came to this trial?
Yeah, they randomized about 1,000 patients to Resmetirom versus placebo and looked at the same endpoints as the Essence trial. They showed mass resolution in 30% with the 100 milligram dose, 26% with the 80 milligram dose, and 10% with placebo.
And that 100 milligram dose showed a 52% reduction in liver fat fraction as seen on MRI. And so it emphasizes like a lot of the benefits here are probably through the reduction of liver fat.
Yeah, so let's take a look at the fibrosis. Fibrosis improvement occurred in about 26% of patients taking Resmetirom 100 milligrams, 24% with 80 milligrams, and 14% with placebo.
Okay, there is some signal beyond placebo, but what about the safety data? Because I don't know, something about you guys telling me that a part of our bodies becoming thyrotoxic makes me a little nervous.
Yeah, it made me a little wary too, Shreya, but I'll be honest, the safety profile looks pretty reassuring. Most patients had only mild gastrointestinal side effects, and then there were small decreases in free T4 that remained within the normal range. And there were no major thyroid or cardiac signals, which is obviously all of our major concern. That said, longer-term data will be important for us to watch for additional side effects that pop up.
Well, now that we're talking about caveats, I do want to say something about accessibility. Resmetirom costs about $48,000 per year. That's roughly $170 per tablet.
Oof.
Yeah.
So that's like 1,000 patients for like 12 generations of rosuvastatin and metformin. Hearing those numbers is the first time I think literally in my whole life I have ever felt sympathy for the person on the other end of that prior authorization phone call.
It's painful on all sides. Ugh.
Yeah. But once we get past all of those caveats and obstacles, let's take a step back and look at MASLD and MASH from an intellectual perspective. We have this condition that has been kind of impossible to treat for a generation, except when patients get sick enough to need a liver transplant. And now we have two drugs, two totally different mechanisms, no overlap in how they work, and both of them lead to improvement or even remission of this condition. We've had so many wow moments when we talk about new medical research on this podcast, but these two trials, MAESTRO-NASH and Essence, like these are wow moments for me.
Yeah. And then the fact that both of them work is just strong evidence for that underlying hypothesis being correct, right? That hypothesis that liver fat is toxic. And so if you reduce it in whatever way you can, if we reduce that fat, we can reverse inflammation and even fibrosis, which is a pretty remarkable validation for that excess fat toxicity model.
By and large, the person with MASH, with F2 or F3 fibrosis, what that person really needs is a resolution of the underlying condition that led their liver to be sick in that way. And that's why weight loss is number one, through whatever means possible. If it happens through diet, fantastic. If it happens through bariatric surgery or pharmacologic therapy, also awesome. And then in sequence, if that person still has a high risk for cirrhosis or F3 fibrosis, that's a person that definitely needs one of these liver-directed therapies, the Resmetiroms, the efruxifermin. You'll have some people advocate that you can use both drugs in combination, right? But again, our goal is to reduce overall morbidity and mortality. It begins with treating the underlying cause, the insulin resistance, the cardiovascular risk. And then if you're still stuck with liver risk, and you would address that. That's my opinion.
So I just want to point out, in the vein of understanding morbidity, mortality, the totality of how these drugs work, that we don't actually have data about how these drugs are going to impact HCC risk or even all-cause mortality. Patients might not necessarily care about their liver histology until we have evidence that we have benefit of these other outcomes. And so these trials are really, really promising and exciting, but they're not definitive.
Actually, more to come on that. Both of these trials will look at long-term clinical outcomes and liver-related events, including progression to cirrhosis. And I just have to add, when researching for this episode, I was amazed by how much more is coming. There are ongoing studies looking at FGF21 analogs, PPR agonists, and other incretin mimetics like tirzepatide.
It was in the trial of tirzepatide that we saw the most robust reductions in fibrosis. And lo and behold, what was the body weight loss that was observed on average? 10%.
Again, hearing how powerful that 10% weight loss is just makes someone like me, who's like a numbers person, really excited. Like, I love a goal, I love a mission, yes. But unfortunately, it hits home personally for me because my mom, I don't know why she had this right precaution ultrasound so many years ago, but there was some steatosis noted. And I so wish I'd known this, that I could have used that in terms of motivation for weight loss for her. And sadly, like, the issue just got swept under the radar for years. And even as I learned more about MASLD and remember something about steatosis, like, I still felt like I didn't know how to manage it and how and when things should be repeated.
So I look at a patient like your mom, and I look at these two trials. And to me, this is really good evidence that a patient like your mom should be followed longitudinally over time. It doesn't necessarily need action at this moment, but now that we have these treatment options, we should be following people and making clinical decisions about when to intervene pharmacologically.
You are fully empowered to repeat that FibroScan a year or two later and then celebrate with the patient or demonstrate that things have gotten more serious. Like, the stakes are higher. You went from 10 to 14. Okay. Like, what didn't we do since the last time that we met? Or you went from an 11 to a 6. You can fire your hepatologist.
Wow, I feel like that's revolutionary. The thought that you might be able to fire a hepatologist or graduate from liver clinic. I mean, this makes me think a lot about the future of MASLD.
So what I think the future is that earlier liver disease, like what the biopsy would have said is F210, right? Maybe elevated ALT. This is not going to be a hepatology patient, right? This is going to be someone that is managed through easily prescribed, largely well-tolerated medications, firmly within the wheelhouse of primary care clinicians who are likely or honestly superior in motivational interviewing and lifestyle management compared to a hepatologist. And then the hepatologists, as regards MASH, NASH, are going to become cirrhosisologists, where your non-invasive tests that you either knew about or were clued into through things like best practice advisories that were wired into the electronic health record would identify the patient who is at risk for liver cancer or decompensation and ought to be followed by a hepatologist.
That is a great premonition to put out there, that the hepatologists are going to be mostly cirrhosisologists. But I think for any of this to kind of happen, the big knowledge translation piece here, and something I definitely have to get better at doing, is that when we do see steatosis on some long radiology read, we need to go ahead and plug in that patient's age, AST, ALT platelet count, and make sure they are at low risk for fibrosis.
And so what I would say for most clinicians is to make sure that your patient is at low risk for advanced fibrosis. And if they are at higher risk for it, to intensify management. And now and in the future, there will be increasingly more tools available to address this problem.
And so let's look at Essence and MAESTRO-NASH as calls to action. MASLD and MASH are finally treatable conditions. And so when we are on the front lines, we see steatosis on imaging and ALT of 55. Even if we're not treating it immediately, this is something to talk about to the patient or flagging it in a discharge summary as something that should be looked at and monitored down the road. If we can identify people for risk for cirrhosis, that's a win. I mean, cirrhosis sucks. And we've all seen people who have miserable lives and miserable deaths who have cirrhosis when they're in the hospital. And so this is something that I personally am transitioning from nihilism to optimism about treating.
Yeah, definitely. I think it's so great that we have more tools to help us along the way and more options to manage this durably over time. I think, as Dr. Tapper said at the beginning, it validates this disease in a way that hopefully can move the needle forward.
And with that, that's a wrap for today's episode. If you got something from this episode, please send it to somebody that you work with and share it with them so that they can learn too.
And as always, we love hearing feedback. Please email us at hello@quariumpodcast.com. Opinions expressed are our own and do not represent the opinions of any affiliated institutions. Thank you and take care. Okay, MASH is the one that is more badness. It's all badness, but worse of the badness. I should not say redo.
That's okay. No.
I mean, you could probably say badness one fewer time.
I felt myself judging myself as I was doing it. I was like, okay, let me try it again.
But then recognizing that our gold standard isn't really the gold standard because it's patchy.
Oh, is that a pun? Patchy? Like patchy areas of fibrosis? Well, that's what you literally are saying, right?
Yeah.
It sounded better earlier this morning. Where I was
I'm not sure what the pun is, but
because
sure,
it's because it's literally patchy.
We'll just have you say that and then we'll sweep her.
We should have you explain the joke, because a joke that is well explained usually lands really well.
We're gonna have you explain the joke. Like, spend one whole minute having you explain the joke.
It took me out a minute. Okay,
all right,
go for it.